There is a common assumption about disease in space. Most people, when they imagine a virus spreading aboard a space station, picture something dramatic: a sudden outbreak, alarms going off, bodies floating in corridors. The reality, if it were ever to unfold, would be far quieter, far more procedural, and in many ways, far more unsettling, precisely because of how ordinary it would begin. Let's start with the environment itself. A space station is not a hospital, not a submarine, not a remote Antarctic base, though it shares characteristics with all three. It is a pressurized aluminum and composite structure orbiting at roughly 400 kilometers above Earth's surface, moving at approximately 28,000 kilometers per hour. The atmosphere inside is carefully managed. Oxygen, nitrogen, carbon dioxide scrubbers, humidity controls, temperature regulation. Every breath taken by every crew member is the product of engineering, not nature. At first, this seems like an advantage. A controlled environment means a controllable atmosphere. You can filter air, you can monitor CO2, you can adjust humidity. But zoom out for a moment, and the same system that sustains life becomes the perfect transmission highway for an airborne pathogen. The air doesn't just circulate, it recirculates. Every molecule of air aboard the International Space Station, for example, passes through filtration systems that were not designed to capture viral particles smaller than 0.1 microns. Most people focus on the obvious impact. Someone gets sick, they rest, they recover. On Earth, that is an unremarkable event. On a space station, the chain of consequences begins immediately and branches in directions that ground-based thinking simply doesn't account for. A crew member becoming symptomatic is not just a medical event. It is an operational event, a resource event, a psychological event, and potentially a mission-ending event, all at once. Begin with the medical reality. A typical station crew is small, anywhere from 3 to 7 people depending on the mission phase. There is no on-call physician in the traditional sense. Crew members receive medical training, but they are not virologists or infectious disease specialists. The medical supplies aboard are finite, carefully calculated for expected contingencies, and resupply takes months. If a virus requires specific antiviral medication not currently stocked, that medication cannot be ordered and delivered within a clinically useful time frame. Now consider the geometry of the station. There is no spare room. Sleeping quarters are essentially closets. Work areas are shared. The dining table, if it can be called that, is shared. Exercise equipment is shared because in microgravity, cardiovascular and muscular degradation begins within days without rigorous daily exercise. That exercise equipment, the treadmill, the cycle ergometer, the resistance machine, it all recirculates contact surfaces. There is no realistic way to quarantine a crew member in a meaningful medical sense when the station's total habitable volume is approximately 900 cubic meters, and much of that is occupied by equipment. At first, this seems like a containment problem. And it is. But the more consequential issue is what happens to the station's operational capacity when even one crew member becomes non-functional. Tasks aboard a station are distributed with very little redundancy by design. Weight and launch costs mean that every system is optimized. Crew assignments are likewise optimized. If the crew member responsible for a particular maintenance cycle, say, the water recovery system, becomes unable to work, that system does not maintain itself. Other crew members must absorb those responsibilities while simultaneously managing their own workloads and potentially managing the sick crew member's care. This is where the cascade begins. Not dramatically, not with alarms, but quietly in spreadsheets and task logs. The station's daily schedule, which is meticulously planned by teams of engineers and mission controllers on the ground, begins to slip. First by hours, then by days. Systems that require regular maintenance begin to approach their service intervals unserviced. Consumables that were calibrated for a healthy, fully operational crew begin to deplete slightly faster than projected because sick individuals in microgravity have different metabolic profiles, different fluid needs, different CO2 output as their respiratory systems work harder. Most people focus on the obvious impact of one sick crew member. What the data actually suggests, based on analog environments like submarines and Antarctic stations, is that illness in an isolated high-stakes environment rarely stays contained to one individual. Not because of any particular virulence, but because of the social physics of small groups under pressure. People share tasks. People share meals. People share the air. And in microgravity, the behavior of respiratory droplets is different. On Earth, gravity pulls droplets downward. In microgravity, they drift. They linger in the air column longer. They travel further from the source before settling on a surface. Zoom out for a moment and consider what it means for two crew members to be symptomatic simultaneously. A 3-person crew is now 2/3 compromised. A 7-person crew retains functional capacity, but the workload redistribution becomes severe. The mission timeline, which has its own gravitational logic, launch windows, orbital mechanics, resupply vessel schedules, EVA plans, does not pause for illness. The Earth does not stop rotating. The orbital decay of the station does not pause. The resupply vehicle coming from Kazakhstan has a launch window that is determined by physics, not by human health. There is a particular moment in this kind of scenario that is easy to miss if you're thinking about it from a distance. It's the moment when mission control on the ground has to make a calculation about whether the station can sustain operations through the illness cycle or whether an emergency crew return is warranted. This calculation is not straightforward. Returning a sick crew member to Earth in a Soyuz or a Dragon capsule is itself a significant medical risk. Re-entry and recovery expose an already stressed immune system to sudden gravity, physical stress, and the complex biological demands of readapting to a 1G environment. A crew member whose respiratory system is already compromised by a virus faces additional strain from re-entry acceleration. There is no ambulance waiting on the landing field in the Kazakh steppe. At first, this seems like a problem that has clear protocols and therefore clear solutions. And protocols do exist. Every space agency has contingency plans. But those plans were written for known contingencies: a broken arm, appendicitis, a cardiac event, a bacterial infection. A novel virus, or even a known virus behaving unexpectedly in the microgravity environment, sits in a different category. There are documented cases of crew members experiencing more severe symptoms from common pathogens during spaceflight than they would have expected on Earth. The immune system in microgravity is suppressed. Not dramatically, not catastrophically, but measurably. T-cell activity changes. Latent viruses like the herpes simplex virus have been observed reactivating in spaceflight crew members. The body in space is immunologically not the same body that launched from the pad. This means that a virus which would produce mild symptoms in a healthy adult on Earth might produce more significant symptoms in the same person after 90 days in orbit. The crew member is not weaker in a general sense. They are physically fit, rigorously selected. But the specific mechanisms that manage viral infection are operating at reduced efficiency. This is not speculation. This is documented in peer-reviewed literature from NASA and the European Space Agency. The practical implication is that the illness duration may be longer, the severity may be higher, and the recovery timeline may be less predictable than ground-based medical models would suggest. Consider now the question of diagnosis. On Earth, a sick person goes to a clinic, a swab is taken, a test is run, a result is returned, often within hours. Aboard a space station, diagnostics are limited to what was launched. There are portable diagnostic tools aboard, capable of basic blood analysis and some PCR-based testing. But these tools have a finite reagent supply. Running repeated tests on multiple crew members depletes that supply. If the virus is a known pathogen that falls within the station's diagnostic capability, that is the best case. If it is novel or if it presents atypically, the crew is essentially relying on symptom management without confirmed diagnosis, which affects treatment decisions, affects how aggressively to use the limited antiviral or supportive medication supply, and affects the accuracy of the information being transmitted to ground medical teams. Most people focus on the obvious impact of limited medicine. What is less visible is the psychological texture of this situation. A crew member who is ill, who does not know precisely what they have, who knows that the medical supplies are finite, who knows that their illness is affecting their colleagues' workload, who knows that a resupply vehicle is months away. That crew member is managing a very complex psychological load simultaneously with a physiological challenge. Research on isolated confined environments consistently shows that even mild illness in high-stakes operational settings produces anxiety responses disproportionate to the medical severity, because the context amplifies the stakes. The other crew members are managing their own psychological load. They are absorbing extra work. They are potentially managing their own mild symptoms and deciding whether to report them or continue working. This is a known phenomenon in analog environments. People in high-stakes, isolated settings underreport symptoms because they do not want to be perceived as a burden, because they do not want to compromise the mission, because the social dynamics of small crews under pressure create implicit pressure to perform. An Antarctic researcher will walk on a sprained ankle for days before reporting it. A submariners will manage a fever with over-the-counter medication rather than report to the medical officer. Astronauts, selected for psychological resilience and mission commitment, are not immune to this dynamic. They may be more susceptible to it. Zoom out for a moment to the broader system surrounding the station. On the ground, teams of engineers, flight controllers, medical officers, and mission planners are managing the unfolding situation in real time. This is itself a significant operational burden. Flight control rooms that are normally managing nominal operations are now managing a contingency. Resources are being reallocated. Specialists are being called in. Communication windows with the crew, which are not continuous, which have latency of roughly 0.5 seconds at minimum due to the speed of light across the orbital distance, become the critical information pipeline. The crew cannot have a real-time conversation with a doctor in the traditional sense. There is enough latency that natural back-and-forth dialogue feels interrupted. More practically, there are scheduled communication windows and periods of communications blackout, depending on orbital geometry and relay satellite positioning. In a deteriorating medical situation, a communication blackout of even 20 minutes creates a gap in situational awareness for the ground team that can feel catastrophic in a way that is hard to convey to someone who has never worked in mission control. At first, this seems like a solvable communications engineering problem, and for most scenarios, it largely is. But the combination of limited communication continuity, limited diagnostic capability, limited treatment options, and a degraded crew in a high-maintenance environment creates a compounding pressure that is qualitatively different from any single one of those factors in isolation. The sum is not equal to the parts. Now consider the longer timeline. If the illness cycle runs its course without requiring emergency return, which, statistically, is the most likely outcome, the crew emerges from the acute phase into a recovery phase that has its own challenges. Fatigue following viral illness in microgravity takes longer to resolve than it would on Earth. The muscular and cardiovascular exercise regimen that prevents long-term spaceflight health deterioration cannot be paused during illness and must be resumed carefully during recovery. A crew member who lost 10 days of exercise to illness has experienced measurable bone density and muscle mass changes that compound on top of the normal losses from microgravity itself. The mission timeline has drifted. Science experiments scheduled for that window may have been missed or compromised. Data that cannot be retroactively collected, atmospheric measurements, biological sample collections timed to specific orbital cycles, is simply lost. For missions with commercial partners or international scientific collaborators, those losses have downstream consequences in research programs and institutional relationships. Not catastrophically, but cumulatively. Most people focus on the obvious impact of the illness itself. What the post-illness phase reveals is the structural vulnerability that was always present, but becomes visible only under stress. The station's maintenance log has fallen behind. The crew's physical condition is slightly below where it should be for this phase of the mission. The consumables budget, water, food, medical supplies, has been drawn down more than projected. The psychological reserves of the crew have been tested. All of these factors make the crew and station more vulnerable to the next disruption, whatever form it takes. Zoom out further now, to the policy level. Space agencies review contingency events after every mission. If a viral illness event occurs and results in mission compromise, that event generates an extensive formal review. What was the source of infection? Pre-launch quarantine protocols typically impose a health quarantine period of 2 weeks before launch. The crew is isolated from the general population, tested repeatedly, monitored. Yet, respiratory viruses with short incubation periods, some influenza strains have incubation periods of 1 to 4 days, can theoretically pass through this window undetected. A crew member who becomes infected on the last day of quarantine after final testing might board the launch vehicle with a viral load below the threshold of detection. This leads to a difficult policy question. If pre-launch quarantine is extended to 4 weeks or 6, what are the human costs of that isolation on crew performance and psychological readiness? Long pre-launch isolation itself has documented negative effects on crew cohesion and morale. There is a real trade-off between infection prevention and crew readiness. Extending quarantine does not eliminate the risk, it reduces it at a cost. At first, this seems like a narrow technical debate within space medicine, but the implications are broader. As commercial spaceflight expands, as the number of people traveling to and from orbit increases, the population exposed to the pre-launch risk window grows. A large commercial station, the kind that Axiom Space and others are developing for the 2030s, might house a dozen or more people, rotating on schedules more like an offshore oil platform than a traditional astronaut mission. The occupants will not all be career astronauts with decades of medical screening. They will be commercial researchers, tourists, technicians. The infection control protocols that were designed for a crew of 7 highly selected individuals will need to be rethought at scale. Consider the economic dimension. A commercial station represents a capital investment in the billions of dollars. The operational cost per day is substantial. A viral illness event that grounds the crew and compromises operations for even 2 weeks represents a direct economic loss in the tens of millions of dollars when you account for lost research time, delayed maintenance, and the cost of emergency consultation and contingency planning by ground teams. Insurance structures for this kind of risk are still being developed. The actuarial data simply doesn't exist yet at the scale that commercial insurers require, which means that early commercial operators are carrying a risk on their balance sheets that is difficult to quantify. Zoom out for a moment to the geopolitical dimension. The International Space Station is a collaboration between 5 space agencies representing 15 countries. A health event aboard the ISS has diplomatic as well as operational dimensions. Who is informed, when, and how? If a Russian cosmonaut becomes ill from a pathogen that appears to have originated in the pre-launch quarantine facility in the United States, how is that communicated, investigated, and resolved without creating friction in what is already a complex geopolitical partnership? These questions have no elegant answers. They are managed through existing frameworks, joint medical operations agreements, data sharing protocols, formal incident review procedures, but the management itself takes time and resources. Most people focus on the obvious impact of the health event. The less visible consequence is what the event reveals about the adequacy of existing international frameworks for managing shared human infrastructure in space. The ISS cooperation model was built in a period of relative geopolitical stability. As the geopolitical landscape shifts, as new space-capable nations develop their own station programs, the question of shared health protocols across politically separate stations that nevertheless share the same orbital environment and the same resupply and crew exchange infrastructure, becomes genuinely complex. At first, this seems very far from the initial question of a single virus on a space station. But this is how systemic analysis works. You begin with a specific event. You trace its consequences through the systems that surround it. You find that the systems are connected in ways that are not always visible until they are stressed. The question of viral transmission in space also opens a conversation that the space medicine community has been having quietly for years, but that rarely reaches public discourse. The question of whether humans could, accidentally, bring Earth pathogens to other worlds, or bring back novel biological material from other environments, however unlikely that seems in the near term. Current planetary protection protocols require extensive decontamination of spacecraft visiting other worlds, but those protocols were designed primarily around bacterial contamination. The viral question is more complex, partly because of the difficulty of detecting and eliminating viral particles, and partly because the definition of a virus as a biological entity is itself philosophically complicated. Viruses are not alive in the way that bacteria are alive, yet they can replicate and evolve using living cells as substrate. This is a long way from a crew member with a fever on the International Space Station, but the chain of consequences, followed rigorously, leads here. Because the decision-making frameworks, the protocols, the technical capabilities that would govern a viral event aboard a current station are the same frameworks that will govern far more complex situations as human spaceflight extends in range and duration. The ISS is, among many things, a laboratory for understanding how humans and human systems behave under conditions of isolation, confinement, and resource constraint. Every contingency that occurs aboard it, every protocol that is tested and refined, every gap that is identified and addressed is informing the design of the systems that will support lunar bases, Mars transit vehicles, and whatever comes after. Zoom out one final time. A virus on a space station is, in one sense, a contained and manageable event. The crew is small, the duration of illness is finite. The range of likely outcomes for a crew in good health with access to reasonable supportive care is favorable. Most crew members who become ill in space recover. The station continues to function, perhaps at reduced capacity, but it continues. But in another sense, a virus on a space station is a stress test of extraordinary scope. It tests the physical design of the station's life support and air management systems. It tests the adequacy of the medical supply chain and the diagnostic capability. It tests the protocols for crew decision-making under uncertainty. It tests the communication frameworks between crew and ground. It tests the psychological resilience of small teams under compounded pressure. It tests the administrative and diplomatic frameworks that govern shared human infrastructure. And it tests the insurance and economic models that underpin commercial spaceflight. What we find when we look carefully is that most of these systems pass the test, but not always for the reasons we expected, and often with margins that are narrower than they appeared from the outside. The survival of a space station crew through a viral illness event is not evidence that the system is robust. It may be evidence that the system got lucky this time, and that the stress test has identified specific vulnerabilities that will need to be addressed before the next test, which will come in a different form, at a different time, with a different margin. That is the real lesson. Not that space is uniquely dangerous. It is. But that danger is known and managed. Not that illness in space is catastrophic. It is serious, but it is manageable. The lesson is that complex systems under stress reveal their actual architecture, not the architecture that was planned. And the most important work that any organization running human spaceflight can do is to take those revelations seriously, without drama, without defensiveness, and with the patient analytical attention that the situation requires. Because the next viral event will happen. The question is only whether the systems it tests will have been improved by what the previous one revealed.